And thank you for coming. Happy Valentine's Day to all of you. I hope you got your sweethearts the appropriate Valentine. So isn't it appropriate that on a day like Valentine's Day, we're going to talk about something sweet? And that is the management of diabetes. As I've mentioned in the past, we like to tell the audience of new resources that have come available at Hoag that you don't have to search so far, and this is one of them. Dr. Daniel Neto is how he pronounces it, was just selected a short time ago as become program director for the Mary and Dick Allen Diabetes Center, and sits in the first endowed Chris Iyer Chair in Diabetes Care, and he brings these resources to us here at Hoag. He trained back east where there's a lot of snow in Tufts, residency in Vermont, fellowship in Vermont, research fellow in Vermont, and finally found his way to the West Coast. He's board certified in all the appropriate boards, as you can see. He's, as already mentioned, medical director of the Diabetes Endocrinology Associates of York Hospital in the past, medical director of Health Reach Diabetes Education Endocrine and Nutrition Center. He was assistant clinical professor at Tufts, director of their Diabetes Center Nutrition Support. He is a medical reporter, and you'll learn more about that. In Maine, he's currently president-elect of the American Diabetes Association for Maine, associate medical director of the Abbott International, has appeared on CNN discussing diabetes and nutrition. He did his research fellowship in Vermont, has participated in over 50 clinical trials, extensive corporate research experience, research assistant at Clinical Nutrition Unit at Boston University, USDA Research Center at Tufts, and also Department of Psychology, University of Maine. He published The Color Code, a revolutionary eating plan for optimum health that hopefully we'll hear about today with numerous books, book chapters, and the like. He's given many lectures throughout the area on endocrinology and epidemiology and other nutrition issues. These are his objectives that are listed on the back of his evaluation form. And here are his disclosures that we've looked at as a CME committee and find no objection to them. Oh, I forgot to mention this CME schedule that's out in the hospital website says that next Friday, Grand Rounds is at 7:30 in the morning. No, it's at 12:30, and you'll see a list of all of the topics coming up in the next couple of weeks outside by the sign-in sheet. So will you please turn off your cell phone and pagers or put them on mute and join me in welcoming Dr. Neto.
Well, it's great to be here, and we'll talk about managing highly motivated patients. I think when we have people with diabetes, we often think of them as not being very motivated patients, but I think there are a number of patients with diabetes that are really motivated, and we can really take them a long way. I'm going to update you on a conference that I recently went to last week in Vienna. This is a picture from one of the gardens in Vienna. It's a picture of Johann Strauss. And I think it's appropriate too because he was the guy who really brought to new levels the music of the waltz, which is I think appropriate for Valentine's Day, and certainly was a very motivated patient. So we'll end up talking about pumps, pills, and potions for managing diabetes. Again, this is the faculty disclosure form. We'll talk a bit about the history of diabetes with a focus on type 1 diabetes. It's always very fascinating to kind of reflect on where we've come from. Epidemiology of diabetes. Then we'll focus on type 2 diabetes with an emphasis on GLP-1 receptor agonist, and then the newer Sglt2 blockers. We'll talk about insulin and its use, and then we'll talk about type 1 diabetes, where we are with pumps and sensors, the artificial pancreas and the bionic pancreas. I have a couple, if you see a yellow dot, that suggests that it may be on the label for the medication, but it's not, there's no FDA indication for the use. And then if we see a red dot, that suggests that it's experimental. So certainly diabetes is an epidemic with some 26 million Americans diagnosed with diabetes. In 2008, they suggested that 40% of Americans greater than age 20 either had pre-diabetes or diabetes itself. So it's a huge part of what's happening in terms of health care. I won't read through those other statistics in the interest of time. The costs are astronomical, and we're having, more and more young people actually even develop type 2 diabetes. When we thought about diabetes in the past, we thought about age 40 and over as being type 2, but it's creeping down. Type 2 is occurring in younger and younger population, even teenagers now. So originally 1500 BC in India, they found that people had urine that would attract ants, so the glucose in their urine would attract ants. And it was something where insulin is the storage hormone. It basically allows you to bring on fat and muscle. It's an anabolic hormone, and without it, you basically melt away. And this was described in year 150. And then Greek physicians prescribed horseback. There weren't any medications or treatments that really worked. 1869, Paul Langerhans discovered islet cells in the pancreas. And they found that by removing the pancreas in 1889 that they could actually induce diabetes in dogs. And then in 1921, Banting and Best showed that a pancreatic extract lowered blood glucose in pancreatomized dogs. So before insulin, it was a death sentence. This even occurs today. I had a friend who went down to Mexico and, basically was telling people with diabetes that because they had no insulin available, that they should go home and expect to die within a few weeks. So this happens today. It's a tragedy when it occurs. You can see this picture taken here and the young child who's basically lost all of his fat mass, all his muscle mass, because there was no insulin. And then 2 months later, with insulin, you can see the dramatic difference it made for him. This is Banting and Best, and a little known fact is that Dr. Iyer, back in 1922, was a president of the University of Toronto. You can see him there in the background. And then you see, so Banting and Best, and then the dog's name was Marjorie, actually. They got a lab with 10 dogs, and they performed their experiments where they pancreatomized dogs. They created an extract from the pancreas and were able to control the blood glucose. This was the experiment done by Banting and Best. The first person to receive their concoction was Leonard Thompson, and he got 7.5 mLs of a thick brown muck into each buttock, and it was found that it lowered blood glucose. He did have some abscesses that eventually healed. Back at that time, it was before we had penicillin. He actually died of pneumonia at age 27, 13 years later. So insulin was first produced. The first bottles were a concentration of U10 insulin, and then over time, U40 insulin was pretty clean, and abscesses were much less common. So the Nobel Prize went to Banting and McLeod, who had the lab where Banting and Best worked. DNA technology eventually developed human insulin, and then with being able to monitor glucose, we had glucose self-management, which was a powerful tool. And then more sophisticated analogues developed, and then we continue to work towards cures for type 1 and type 2 diabetes. Just a comparison of the two, type 1 is usually a more abrupt onset. Certainly, body mass is a great indicator. When you see somebody coming in to see you, regardless of their age, if they're very slim and they have diabetes, you need to think type 1. In terms of twin concordance, type 2 actually has a higher twin concordance than type 1. And HLA antigens are more closely associated with type 1 as opposed to type 2. Autoantibodies are rare in type 2. About type 2 represents about 90% of diabetes in the U.S. About 10% is type 1. So we're seeing, obesity trends in the U.S. really, increase dramatically over time, 1990 up to 1999, and then you can see, there's places where there's over 30% obesity, and in those same states you see, huge increases in diabetes, with some areas having over 9% of their population with diabetes. You also see higher risk in Asian Americans, Hispanic, Latinos, as well as Black people. And worldwide, it's an absolute growing epidemic, and you can see just the change from 2000, 2001, 2003, and then expected in 2025 there'll be pockets of the population worldwide where over 17% of the population will have, type 2 diabetes. So a big problem. In terms of goals, basically you want to try to get glucose as close to normal without causing hypoglycemia, and some of the newer meds we'll discuss today allow you to do that without causing hypoglycemia. In older people, you may have looser goals in nursing home populations, for example. Diabetes is certainly progressive. You see that over time, the glucose levels tend to rise. In type 2 diabetes, there's a component of insulin resistance. By the time you're diagnosed, it's thought that beta cells are functioning about 50% of capacity. And you see incretin effects also. We'll come back to that over time, but beta cell failure, and then the development of overt type 2 diabetes. Macrovascular changes are occurring early on. About 20% of people with new onset type 2 will actually have some retinal changes, and then those retinal changes, kidney disease from microvascular changes occurs over time as well as neurological changes with neuropathy developing. If you control glucose, you can prevent these complications, as was shown in the Diabetes Control and Complications trial. If you can keep, and really the way we define diabetes itself is when you actually develop a risk for retinopathy or microvascular disease. And when your A1C is above 6.5, that's when you start to get an increase in terms of retinopathy. If you can keep it under 6.5, you can pretty much prevent it. But if you have an A1C of 10, then your risk is dramatically increased. And what was shown in type 1 diabetes is also true in type 2 diabetes, showing here a 1% reduction in A1C and the reduction in risk of various microvascular as well as macrovascular complications. We still have a long ways to go in terms of achievement of ideal A1C. There's a big part of the population that has A1C over 10, big part over 9, and and some close to 40% A1C over 8. So we have a long way to go in terms of achieving that goal of either under 7 or under 6.5. So in the past, when I was a resident, we had insulin and sulfonylureas to treat people who had diabetes, and this led to a cycle of increasing weight gain with worsening diabetes over time, need for more insulin and more medications. And you can see from the UK PDS and the intensively controlled where they're using sulfonylureas as well as insulin, that weight just continued to go up over time, and that A1C deteriorated as well with overall continued use of those medications. This is the long list of medications now that we have to treat type 2 diabetes. I'm going to focus on just a couple of them today in the interest of time. If you have any specific questions on any, we can come back. But we're going to talk about the Glucagon-Like peptide receptor agonists, and we're also going to talk about Sgl2 inhibitors, as well as touch on Metformin and insulin analogues. This is the more recent ACE guidelines that have been created, and what I'd like to point out here would be the use of the suggestion of using GLP-1 receptor analogues early on. That basically comes out as the first on the list right across the board here. One thing that I wouldn't suggest is the use of TZDs, and I'll show you why in a few minutes, why I don't use them. In terms of how these agents work, you have the GLP-1 receptor analogues working on maintaining the beta cell of the pancreas. We'll talk about the variety of different effects there. Glitazones basically convert virtually every cell in your body, whether it's going to be a muscle cell or a bone cell, into fat cells. And this has, in my mind, a clear disadvantage. Metformin works to reduce glucose production from the liver. Will alpha-glucosidase inhibitors lead to a lot of divorces potentially because of all the gas production that occurs? Probably best avoided. Sulfonylureas in the recent European Association for the Study of Diabetes was associated with a high risk of cardiovascular events If you're going to use these agents, use them only at low dose. They really don't work more effectively at higher dose. And then we'll talk about the Sgl2 receptor inhibitors as well. So these are the various agents working on different parts of the body. I've already introduced them. And in terms of metformin, we know that you have GI side effects. One thing I'd like to mention is that metformin does not cause kidney problems. Okay, people say, well, you know, we don't want your kidneys to get worse, so we're going to stay away from metformin. Metformin is really only a problem for people who have existing renal disease. If there's a problem with clearance of it, then you're potentially at risk for lactic acidosis. It's very rare. There have been about 14 cases described in the literature. They're generally in people who have very high creatinines with high doses of metformin continued at the same time that an iodine contrast agent was used. It's really very rare that it occurs, but metformin does not worsen kidney disease. That's I think, a common misconception that's out there. The other one I'm going to focus on is TZDs. I don't use these agents at all. They cause weight gain, they cause edema, they could potentially worsen heart failure. My big problem with them is the effect on bones, and we'll come back to that right now. This is looking at a rat who's been given rosiglitazone, and you can see basically the loss of bone within the marrow and the infiltration with fat cells. So those cells that would normally become other cells are actually becoming fat cells. Your marrow becomes infiltrated, and you can actually see the suggested bone loss actually occurring right here in this animal. If you look at the fracture risk in those, even in the registration trials for rosiglitazone, you can see you had a doubling in fracture risk, even in the relatively short registration trials. The most dramatic example is from the UK General Practice Research Database, and this occurred in both men and women, both under age 70 and older than age 70. Risk of hip or femur fracture was increased a dramatic 4.5-fold with the use of these agents. So to me, that represents a real problem. Data presented in New Orleans for the Medco database suggested in the U.S. about a 40% increased risk in fracture when TZDs were being used. There's still some serious advocates. Ralph DeFranzo, who's kind of one of the gods of diabetes in San Antonio, still advocates the use of glitazones like Actos. Personally, I don't. I tend to suggest the use of metformin, a GLP-1 receptor analog, SGLT2, as we'll come back to, and then insulin as needed. So metformin, reliable A1C reduction, inexpensive, reduces glucose output from the liver, slight weight reduction, no risk of hypoglycemia. It's associated with a 41% reduction risk of cardiovascular events for the UK PDS study. Does have some GI side effects, but those are, there if they're there, they're not if they're not. Does not worsen renal function, but is cleared by the kidneys. And again, lactic acidosis is really a rare side effect of it. The GLP-1 receptor analogs, these came along in fairly recently. There were infusions of GLP-1 given by pump, which showed over 6 weeks a reduction in A1C, reduction in blood pressure, reduction in weight, improvements in cholesterol without any hypoglycemia. So there was a really smart guy working at the VA in the Bronx, New York, and he basically looked at peptides in nature that had peptides that were similar to the human GLP-1, and found that the saliva of the Gila monster had a peptide that had 53% homology to human GLP-1. And that led to the first GLP-1 being developed. So we have a variety. Exenatide was based on this saliva from the Gila monster, Byetta, and then now the weekly Bydureon. We have liraglutide, which is Victoza. Lixi is another one that's approved in Mexico and the EU, probably coming here fairly soon. And we have DPP-4 inhibitors that are listed here as well, which do control glucose to some extent, only about a 0.4 to 0.6 reduction in A1C, but still some beneficial effects, not really as far as weight goes, pretty much weight neutral, whereas we'll talk about GLP-1 receptor agonists really do promote weight loss quite significantly. So GLP-1, is released with a mixed meal. This hormone is very, very rapidly broken down. It has a half-life of only 1 to 2 minutes, and then it basically becomes inactive. So DPP-4 receptor agonists are basically designed to not be broken down by the DPP-4, and you also have the DPP-4 blockers that allow for your own body's GLP-1 to survive for a longer period of time. If you look at the serum concentrations when you give something like the Victoza or the Byetta, you can see you're achieving levels that are 4 to 5 times higher than physiologic levels. When you give a DPP-4 inhibitor, you have just maintenance of physiologic levels. So you have a real difference here in terms of the serum concentrations. It's really at these higher levels that you're suppressing the appetite, that you're slowing gastric emptying, that you really see a robust effect in terms of weight loss. You have some increased insulin secretion, reduction in glucagon with the lower levels, but you're not really getting the big weight loss that you're looking for. And that's shown here in terms of reducing food intake. It's really with the GLP-1 receptor agonists as opposed to the DPP-4 inhibitors that are shown there. So GLP-1 is a natural hormone. It's secreted on ingestion of food. The beta cells release more insulin. They become more robust looking. I'll show you that in a second. Your alpha cells produce less glucagon. That slows gastric glucose release from the liver. And in the stomach, you're slowing gastric emptying. So for the first time in their lives, people are actually leaving a restaurant only eating half of their meal. And it actually crosses into the brain and promotes satiety and reduces appetite. So it's almost like the holy grail for treating type 2 diabetes. This is based on a paper by Ralph DeFranzo, who I mentioned earlier, the ominous octet in terms of things that are going wrong in type 2 diabetes. And it really hits 5 of the 8 different defects in type 2 diabetes. You're addressing the decreased incretin effect, you're facilitating insulin secretion, you're reducing glucagon, which reduces hepatic glucose production, and you're also crossing into the brain and reducing the appetite specifically. So you're really going a long way towards addressing the pathophysiology of type 2 diabetes. It's a good time when you introduce a medication, a GLP-1 receptor agonist like Victoza or Byetta or Bydureon, to introduce a healthy lifestyle to, because these people will have less cravings for sugar. It's a good time to try to turn their boat around and focus them on losing weight and get them exercising as well. So the beginning was exenatide, having close homology to human GLP-1 with good receptor activity. It basically stayed in the plasma for up to 10 hours, given before breakfast and supper. Has had a nice effect. And I'm just going to talk generally about GLP-1s. I would call these class effects of GLP-1s, even though I'm mainly showing you data from one medication. It's just mainly for consistency. This is looking at A1C reduction here across the board. You're seeing reductions in A1C of 1 to 1.5, nice drops in A1C, even 1.6 reductions here, about 2 to 3 times what you see with a DPP-4 inhibitor. Across the board, you're seeing nice effects there. You're also, here's again, reductions in A1C. People who had the highest A1C, greater than 9.2, you can see had a 2.3 reduction in A1C, reducing both the fasting glucose, especially with the longer-acting GLP-1, and the postprandial glucose also reduced quite dramatically as well. Here you have to multiply by 18 to get the milligrams per deciliter, so quite a reduction here, a 50 or 60 point reduction in the post-meal glucose. This actually shows a DPP-4 inhibitor, showing that you're able to maintain the beta cells. You can see how the beta cells here look small. They don't have a lot of insulin in them. You put them on, you increase the GLP-1 exposure, and you get a much more robust-looking beta cell. you're increasing replication of beta cells, you're reducing beta cell death, and beta cell mass also increases. So over the long term, if you want to maintain blood glucose control, maintaining beta cell mass is a very important thing, and you do get that with these GLP-1 receptor analogs, as well as with the DPP-4 inhibitors. This is showing improvement in beta cell function as well, and also reduction in proinsulin to insulin ratio. When your body is stressed trying to control glucose, it will put out insulin in an ineffective form in an effort to try to control glucose in the form of proinsulin. And you see normalization of proinsulin to insulin ratios, suggesting that you basically have your pancreas working better in controlling glucose. You're also restoring beta cell sensitivity, as shown here. I won't go into great detail on this. You also, it does not cause hypoglycemia. As blood glucose is normalized, this is a smart way of controlling glucose. Your beta cells are still sensitive to glucose normalizing, insulin levels fall, and you don't induce hypoglycemia, in contrast to what you have with sulfonylureas, which cause insulin secretion no matter what the blood glucose level is through a completely different mechanism. So you're also suppressing glucagon. This reduces insulin release, and you see reductions in weight as well here, where you're seeing, here 4.4 kilogram weight loss, which is, a very significant weight loss. Again, this is showing sustained reduction in weight here over 52 weeks, and a lot of it being visceral. In fact, we'll get back to this, but there were a quarter of patients who lost 7.7 kilograms of weight. So some of your patients, remember, all these studies were done without any dietary counseling. Your patients, if you give them some dietary counseling, what I basically try to get them to do is to eat whole grains, eat lots of vegetables, eat fruits, especially berries, have plenty of legumes and eat healthy proteins, avoid sugar, white flour, beef, cheese, and ice cream and other high-fat foods. And with that, if you give them that simple advice, they can often, go a long way towards really being successful. And you will have patients who lose 100 pounds, with the introduction of this medication. Those people who have higher BMIs tend to lose the most weight, as shown here, BMI over 35. They lost the most weight. Here compared to insulin, the insulin glargine, where they tended to gain weight. Most of the fat that they lose is from the visceral component of fat, losing almost twice the amount as they do from the subcutaneous fat, so there's very significant changes there. Virtually no risk of hypoglycemia because you're controlling glucose in a smart way. You also see reductions in systolic blood pressure with this medication. Here you see about a 3-point reduction in systolic blood pressure. This is something that's seen with all the GLP-1 receptor agonists. And this is a nice effect to have for these people who tend to have very high blood pressure. And you get a reduction in systolic blood pressure right away, even before weight starts to fall. You also get improvements in the lipid profile. These data come from the end of the trial where they had no comparison group, and so there's no indication for reductions in lipids, but generally people staying on these medications do see nice effects in terms of triglyceride reduction, total cholesterol reduction, and you can see here in this study 24% increase in HDL cholesterol, which is otherwise very, very hard to do. Here's a comparison to insulin, similar reductions in A1C in this study, about 1.1 reduction in A1C, whereas those who are on the insulin had a 4-pound weight gain, whereas had a 5-pound weight loss with the GLP-1 receptor analog. Here, another one, virtually the same effects here with weight gain with the insulin, weight reduction with the GLP-1 receptor analog. The GI side effects, which you need to tell people about early on, tend to go away over time. And so, you're seeing that you're getting reductions in body weight, systolic blood pressure, lipids, and not so consistently with the DPP-4 inhibitors, but some improvement here in systolic blood pressure, pretty much weight neutral with DPP-4. In terms of cardioprotection, there have been trials done in people coming in with MI showing that when you use a GLP-1 receptor analog that you're improving left ventricular wall motion. You're reducing hospital stay, reducing in-hospital mortality, and that's in people both with diabetes and without diabetes. People with low left ventricular ejection fraction, you're seeing improved ejection fraction, increased oxygen consumption, increased ability to walk, increase in quality of life scores, and also improved myocardial salvage after ST elevation as well. So when I have patients come in with heart failure, using a medication like this, oftentimes I find not only reduces weight, makes their life better, but it's probably having some effect on improving heart function as well. Even though this would be considered experimental therapy, it's still pretty impressive. The studies are fairly consistent here. I'm going to turn now to another medication, the Sglt2 inhibitors, where you're focusing on the increased glucose resorption that's seen in type 2 diabetes. What happens in type 2 diabetes is your body is trying to hang on to its glucose, which is normally would try to do. Glucose levels are higher. The threshold for resorbing insulin is actually moved up, so you actually keep on normally the kidney will spill out glucose when your glucose is 140, but in type 2 diabetes it may go to 220 or 240, and your kidney is still hanging on to that glucose, kind of thinking it's still, back in thrifty gene mode, trying to hang on to those carbohydrates. So it shifts up, and what these medications do is shift that curve down. So basically glucose over 80 will be spilled out into the urine with the loss of calories. These are fairly new medications. The kidney is normally filtering about 180 grams of glucose each day. Virtually all the glucose that is spilled into the urine is reabsorbed by the proximal tubules, 90% in the proximal, by the SGLT2, and about 10% in the distal tubule by the SGLT1. And this allows for virtually no glucose to be excreted in the urine. You can imagine, during evolution, we wanted to hang on to our calories. It was effective then. So you have the SGLT2 here in the proximal part of the tubule. You have the SGLT1 in the distal, and 90% is basically pretty much by mass effect by these receptors, the SGLT2. And what you're doing with this medication is you're blocking the SGLT2, so the glucose basically keeps on going south, and with that you're able to spill out some glucose. So SGLT2 is a low affinity, high capacity glucose transport that resorbs about 90% of the glucose that's spilled into the urine initially. There is a mutation that's seen in nature of the SGLT2 transporter. It causes hereditary renal glucosuria, which really doesn't cause any problems for these people. They actually don't have diabetes. They don't have the side effects that I'll talk about in terms of urinary tract infections or mycotic infections that are seen in some people with type 2 diabetes. They tend to be a little lighter than most people because they're spilling out those extra calories. And now we have these selective inhibitors that we'll talk about that allow for glucose to be spilled out. It decreases glucose toxicity, and that has all kinds of different benefits. And you're basically spilling out some 75 to 100 grams of glucose per day. Remember, glucose has 4 calories per gram. That means translates into somewhere between 300 and 400 calories per day heading south, which is a fabulous thing. There's been suggestions that you are increasing insulin sensitivity in the muscle and in the liver. You're reducing gluconeogenesis, and that beta cell function potentially improves as well. We have 2 of them that are now approved. One just very recently approved. This one approved about about a year ago, and a few others that are coming our way as well. In terms of approved doses for the gliflozin, or whatever. Sorry. These the approved doses are 100 and 300, and you can see nice reductions in A1C. You see body weight tends to go down here, quite dramatically, 2 to 3.4% reduction in body weight. most people in these studies weigh about 100 kilos, so they're basically losing about 3.4 kilos or about 6 or 7 pounds, a nice effect there. In terms of, there's an increased risk of urinary tract infections as well as mycotic genital infections. It's something you have to warn people about. And in some people who are prone to these, or say when they've had an infection like this, it's been the worst experience of their life, you may want to think twice about using these agents in them. Some of the, this is another agent that's now available, and you're looking at the changes in A1C here, about 0.6 to 0.8 reduction here. The doses that are approved for use in the US are the 5 milligram and the 10 milligram dose. And here again, you see the reduction in body weight as well. So it basically works, without involving insulin. You're losing about 75 grams of glucose or about 300 calories per day. Virtually no risk of hypoglycemia unless you're used with a sulfonylurea. Lowers blood pressure, also helps to get rid of edema in people who have swelling. If they're on diuretics, you may be able to stop the diuretic. It's going to have a similar diuretic effect. It can cause polyuria. About 4 or 5% of people will notice that. Electrolyte disturbances are really rare. This is really independent of sodium. In terms of hypotension, it's extremely rare. Your kidney, God said the kidney will preserve blood pressure at all costs, and it does, even if this medication is on board. That's more a function of sodium balance than glucose balance. And we talked about the risks here. There's really no evidence of increased risk of malignancies with these agents. I think that's going to probably come off any kind of label. And what about insulin? I think that in any patient in whom other therapy is failing, insulin is a good option. Thinking about overall insulin requirements, you think about 0.5 to 0.7 units per kilo as being what a person with diabetes will need. In obese patients, they may require up to 2 units per kilo, quite a lot more. We have a variety of different insulins. We have the very fast-acting insulins. NPH insulin is very inexpensive. We have insulin glargine. We have Levemir as well, which works very flat as well. Ultralente is no longer on the market at this point. There is a new insulin that's being developed, U500 insulin from form of glargine, which if you look up here, suggests that it's a little bit flatter in terms of its effect. And it seems to have a nice effect, probably a little bit flatter than even the Lantus insulin. So it's going to be quite effective, probably available in a pen. In terms of using it, you'll still dial it by units. 2, 4, 6, 8 units should be very easy to use. If you're using a long-acting insulin, I'll typically start with about 0.2 units per kilo, usually giving that at nighttime, targeting a fasting glucose of under 120. If it's over 120, increase the dose by 1 unit each night. When they get up to about 60 units, it's probably reasonable to split it. When you split it, it's going to work a little bit better. Maybe go to 30-30, and at that point, increase by 2 units each day, 31-31, 32-32, 33-32, 33, for example. So, and comparing NPH to an analog insulin here, the analogs, either the Levemir or the Lantus, are going to be a lot flatter than NPH insulin. Earl Hirsch, who's like another one of the big gods of diabetes out there, shows some studies that with Lantus, when you get beyond about 1 unit per kilo, that you kind of lose the benefit of Lantus, and suggests at that point, so in a 100 kilogram person, that would be when you get to like 100 units per day, to just simply switch back over to NPH insulin, maybe twice daily. It's more effective, and the cost savings are really dramatic, as opposed to paying $200 a bottle, a vial. You're paying maybe more like $20, $25 a bottle for NPH insulin, and it has continued effect at the higher doses over 1 unit per kilo. In terms of covering carbs, we get this information from what we know about insulin pumps, the 500 rule, and we can go over this later. I can send you some handouts, but basically we use 500 over 50. This tells you that 1 unit is going to cover about 10 grams of carb. We'll go over this again in a bit. 1500 rule, this tells you how much 1 unit of insulin is going to lower the blood glucose by, gives you the correction factor or insulin sensitivity factor. If somebody required about 50 units per day, the correction factor is 30, and that would suggest that if your blood glucose is 240, that 4 units is going to bring your blood sugar from 240 down to 120. The math is very powerful. If you had a 46-year-old dietitian who weighed 60 kilos, her overall insulin requirements might be about 0.5 units per kilo or about 30 units per day. Give half as the basal, 15 units at bedtime. Then you can calculate her insulin to carb ratio here, 500 over 30, round that up to 1 to 20, and go. So you're going to give 1 unit for every 20 grams of carb, and then in terms of lowering her blood sugar, 1 unit is going to lower her blood sugar by about 50 points. So if she was facing a meal, this is the math that she would use to control her blood glucose. Quite a sophisticated way to do it, but it really works incredibly well. People at the University of Bern in Switzerland are developing an app for your iPhone, where basically what you do is you take 2 shots of your food, and it basically can recognize what the food is, and it will calculate for you the number of grams of carb that you're taking really very effectively, and gives you that information without your having to know how to count carbohydrates. So a powerful tool. Going back to that nurse, basically, let's say she had 60 grams, 60 grams of carb. She would use 6 divided by 23 units to cover the carbs. Say her blood sugar was 220 minus her goal of 122 units for that. So she's taking 5 units of insulin as her pre-meal bolus. We'll skip this for now just because I think the math is getting a little bit crazy, and just kind of keep moving onto pumps now. But we have these variety of different approaches that we can use to try to imitate normal physiology. A normal pancreas is probably putting out about 0.6 units per kilo in a healthy, young, slender person. And then, you can do this trying to give these shots, but if you really want great control, you move towards a pump. This was the first pump, one of the first pumps that was developed. This was actually in Los Angeles. You can see that, wearing a pump makes you very strong. And then the anabolic effect of it. And then this was the next pump. This is more or less like an auto syringe that, was used in hospitals. It was adapted for use as a pump. Still pretty monstrous. And then we had one of the first pumps available commercially that, really got off the ground, shown here. And then a whole variety of different pumps have come along, here since until 1987. This is what's currently on the market. You have Medtronic owns, Al Mann's old company here with the Medtronic Pump. The look of it really hasn't changed in 20 or 30 years. It just basically is a standard pump giving insulin, very accurately. This is one of the new guys on the market. It's called it's from Islet. It's called the Omnipod. And it really, the amazing advantage of this pump is it has no catheter. You can see these catheters here. These are 2 feet long. And when you're wearing this pump, you're dealing with a pump and you're dealing with a 2-foot catheter that's attached to it. This one has a catheter lying underneath it, and you basically tell this device to insert the catheter. It inserts the catheter under the skin, and it gives you insulin continually, and then you control it wirelessly by this device. So very slick. They have a new version of it that's fairly recently released that is very small, and can really take people a long way toward really feeling free. I think our goals with people with type 1 diabetes is to give them a normal life, a feeling of freedom with still control of their blood glucose, and the pumps and the sensors really get them there. This is the tandem pump, which is called the T-Slim, and it is very cool looking. It has a nice interface, very intuitive interface, a lot like an iPhone in terms of interacting with it. Very cool, and here's a few other pumps we won't talk too much about today. In terms of the insulins that are used in pumps, we use the fast-acting insulins, the Novolog, the Humalog, the Apidra. Some people prefer one versus the other. We have a basal rate that's delivered continuously and then a bolus before meals. So the basal is basically providing a steady drip of insulin that's acting continually. It matches the glucose released by the liver, meets the body's basic energy needs, and maybe at different settings for different times of day. So you may want to use a little bit more here as the cortisol levels are rising. You have a bit of a dawn phenomenon, and then go back to a regular, lower rate through the rest of the day. You may actually have your basal rate lower in the dead of the night, because that's not a time where you really want to have hypoglycemia. Bolus insulin is given before meals, as shown here. It's used to cover the carbs in a meal and to correct for high blood glucose levels. It really allows you to approximate normal physiology much more effectively than giving shots. It also allows you to cover snacks. If you have a snack at 3 o'clock in the afternoon, eat an apple, say 15 grams of carb or so, bang, give yourself a unit of insulin, and you've covered that snack without having to give an extra shot. So it really takes people a long way. I use this little Excel spreadsheet in my office every day when I see people coming in with pumps. I throw their body weight right in here, and then it basically tells me an average person starting on an insulin pump, what would their settings be? And insulin carb ratio would calculate out. This is all based on 0.6 units per kilo, giving half as the basal, half as their boluses. Insulin carb ratio would be 10. Correction factor would probably be rounded to 30, and basal rates are shown here. So I can basically go back, and anybody coming in with a pump whose settings may be, way off in, in a different planet somewhere, I can basically bring them back down to normal by looking at what the usual basal rates would be. The pump also allows for temporary basal rates that might be, for example, half of what you would normally give for periods of intense activity. You use infusion sets here. They're shown here. They're inserted with a needle. The needle is pulled out. A little Teflon catheter stays under the skin for most of these pumps. There are still some infusion sets that are metal, which some people prefer. They don't come out. They stay in there very well. Infusion sets are shown here, and you see this one actually, the infusion set is underneath the pod. And then you have a variety of different insertion sets as well. So the pumps are, you would see reduction in A1C, less glucose variability, less hypoglycemia. A lot of people feel they have more freedom in their life, and you get stable blood glucose. So the practical benefits are shown here. You're able to cover that dawn phenomenon very effectively. You're reducing the variation you give a long-acting insulin, the variation may be 50% from one day to the next. With this, your variation goes down to less than 3% just using a fast-acting insulin. In terms of the problems that can occur, the drawbacks of pumps, the cost, quite expensive, extra testing may be required. That small amount of fast-acting insulin, if the pump becomes disconnected, you've got about 2 hours before you start to develop DKA. That's why when it comes to pumps, we have to have people testing at least 4 times a day before we'll consider initiating pump therapy. I think that we're seeing newer pumps that are addressing some of the inconvenience issues around the catheter. This is the Dexcom continuous glucose monitoring system and the readout that you get. In my own opinion, actually, this is the first sensing system that's truly ready for prime time, because its accuracy is really where it needs to be in terms of showing you what the blood glucose is. It gives you a readout every 5 minutes. The catheter lasts for 7 days. You can reset it, have it go for even 10 days or so. It really gives you an amazing amount of information and helps people control their glucose incredibly effectively. Medtronic has a new device that's in Europe now that has an infusion set combined with a sensor. So this is a different company, with the two of them set 11 millimeters apart with no interaction between the infused insulin and the sensor device. So this is experimental, not available in the US, but basically you have this one inserter that in one setting is basically allowing you to insert both catheters at the same time. And this is basically kind of gives you a feel for what this looks like. This is the sensing portion of it, and this is the insulin infusion portion of it, and should be available soon. I would say that Medtronic is making big strides right now towards improving the the accuracy of their sensors, and that's very exciting. So they're definitely moving in the right direction. The big thing with sensors is that you reduce hypoglycemia very dramatically. In some studies, you show improvements in A1C, and others you don't. This is looking basically at a threshold suspend. Medtronic also has a pump that senses, and if the glucose level goes too low, it shuts the pump off for 2 hours. You can reset it. You can have a snack and reset it. This has been shown to reduce risk of hypoglycemia, especially overnight, by about 30%. It's thought that people who have diabetes should not ever go into the water or scuba dive. This is showing an abstract, again, from Vienna, where they, using the Dexcom Sensor, they were able to go scuba diving and know where their blood sugar was the entire time they were underwater. So, basically to be able to live a normal life. This is a sensor that's approved in the EU, made in Israel, not available in the US, basically looking at earlobe for testing glucose. I don't know quite how accurate it was. They talk here about the calibration schemes rather than accuracy, so we'll see. And then I'm going to finish up with, getting close to, this is called the Bionic Pancreas. And there's an engineer who's a biomedical engineer who's at BU, who had one of his daughters. When it comes to type 1 diabetes, people who really have skin in the game are people who either have it themselves or have a close family member who has type 1 diabetes. And he had a daughter who developed type 1 diabetes, and this guy decided, hey, I am going to normalize the lives of people who have type 1 diabetes, and has been working on this for about 7 or 8 years now, and now has what he calls the Bionic Pancreas with really remarkable results, actually. And we'll talk about the pros and cons of it as we go along. But basically, what he's using here are 2 tandem pumps. The way I took these pictures was he was presenting. I sat on the first row, used my iPhone, took a couple pictures, and here they are. So anyway, basically, you have the 2 T-Slim pumps from Tandem. These pumps are very accurate in their delivery of insulin. So he has an insulin pump and the glucagon pump. Theoretically, this pump is able to have 2 different hormones in it, so you could, over time, bring this down to just 1 pump. And that basically is giving either insulin or glucagon. Then you have the Dexcom Sensor, again, what I think is probably the most accurate sensor on the market right now, basically sensing the glucose. And this guy has not really any real dedication to one company. His previous versions used all kinds of different companies' products, but he's using the most accurate one available. And then at that time, this is the iPhone 4S, where he's using the brains of that iPhone 4S to calculate and use to calculate the need for insulin and glucagon based on what the glucose is at any particular time. So he calls this the Bionic Pancreas. He created it. He deserves to call it whatever he wants. This is, again, the equipment. And actually, Kelly has most of this equipment on today, and she can, not for the Bionic Pancreas, but just to kind of get a sense for the different devices. So 2 T-Slim pumps, the iPhone, a little case for transmitting the information. And you see the glucose levels here, basically. So, and they're very, very flat. And I'll have a better picture of that in a minute. So one of the studies he did was the Beacon Hill study, where he had these people going out, and these people were basically told to eat whatever you want. So these people would go to Italian restaurants, in the Back Bay, and just pig out trying to raise their blood glucose, and they basically couldn't do it. The glucose has stayed, remarkably flat using this device, and you can see some of the readouts here. And most of our patients who come in don't have glucose levels nearly this well controlled. So you see 70 here, you see 180 here. You can see virtually all the blood sugars are staying between 70 and 180 virtually all the time. Here you see the insulin being delivered via one of the pumps in blue, and then in red you see glucagon. So whenever the glucose levels started to go down, then glucagon would be secreted by the other pump or put out by the other pump, and he was able to control glucose with an average blood sugar of 132. So one of the things that's going to make this challenging to bring to market is the glucagon, because glucagon, he has an FDA approval for use for 27 hours. Glucagon currently costs about $127 a vial. It doesn't last very long. It means changing out the pump every day. It means but there are some systems where it's smart systems like similar to this, where they're mainly using insulin without the glucagon and getting similar results. So we're basically, coming up with a mechanical solution for type 1 diabetes with some real promise. So what I've tried to do today is talk about, the early years of diabetes. We talked about type 2 diabetes and the epidemic that's occurring. We talked about GLP-1 receptor analogs. We talked about Sglt2 blockers for the kidney, allowing glucose to be spilled out. We talked about an overall goal of facilitating weight loss and controlling glucose. We turned to type 1 diabetes, and we talked about insulin pumps and insulin sensors, and now combining the two in a way that controls glucose and some of the things that are on the horizon for controlling diabetes in the long term. And that's the end.